Hi everyone, welcome to this OMFS Survival Guide session on drug interactions. We're also going to cover a bit on antibiotic prescribing as well. My name's Danielle, I'm a second degree dental student, haven't done medicine, foundation and core surgical training, en route to becoming a MaxFax Reg. So the aims of this session are to understand common drug interactions that we see in MaxFax and how to monitor and manage these. To identify the correct antibiotic to use for specific infections based on the type of bacteria involved, and to be able to identify alternative antibiotics used in penicillin allergy. Now, starting off with case 1. You are the SHO on call and you have seen a 59-year-old male in ED with facial swelling. Now, they have a past medical history of hypertension on atenolol and no other medications, have no allergies, they're a non-smoker, drink about 20 units of alcohol per week and are a HGV driver. Now, you've taken the history. What else would you like to get from the patient or from the notes? You want to have a little look at their observations. So at presentation in ED, they've got a heart rate of 98, a BP of 128/87, SATs of 99% on room air, a temp of 37.4, and a rest rate of 12. Now, what comments do you have about these observations? So they're a bit tachycardic, just on the borderline, heart rate 98, but it's still an important thing to pick up. But everything else seems okay. Obviously, you want to know what the blood pressure is like normally if this patient's a known hypertensive, because 128 might actually be quite low for them. So that's worth just checking with the GP letter or with the patient to know what their normal blood pressure range is. So you move on to examine the patient, and you can see that extraorally they've got a mild facial swelling to the mid-cheek, not impacting the eye at all. They can still open their eye nice and easily. And intraorally, they've got a palpable swelling in the upper left 5-6 region. So moving on to investigations that you'd like to get this patient whilst they're sat in the ED chair. You'd like to get an OPG to have a look at the teeth in a bit more detail to see which one is potentially causing the abscess. It would be wise to get some bloods to have a look at the infection markers and see what's going on. And then any other relevant history, so any previous dental abscesses, do they have a general dental practitioner, etc., etc. Obviously not in this case, but if the patient was on warfarin, you potentially think about getting an INR on those bloods as well. Okay. So how would you manage this patient? So all of their observations are largely stable. They haven't got a fever. They're feeling okay within themselves, still able to eat and drink. So you'd probably be thinking you can manage this in A&E with an incision and drainage and send them home with antibiotics. So you want to cover with analgesia, some antibiotics. Coamoxiclav is probably the most preferred one if they're not penicillin allergic. And then, as mentioned, an incision and drainage in ED, just to get rid of that abscess related to the upper left 5-6. Right, so just to touch on prescribing analgesia in this patient with known hypertension, you have to be careful with the use of NSAIDs. So a bit of basic pharmacology for you all. I'll keep this quite brief, don't worry. But the way that NSAIDs work is that they act to inhibit the COX enzymes, which reduces prostaglandin synthesis. Now, prostaglandins normally work to cause vasodilation and therefore increases the blood flow to the kidneys. So if these are being blocked, the blood flow to the kidneys reduces. And this reduction in blood flow to the kidneys causes an increased retention of sodium. And then this in turn causes increased fluid retention, which actually makes the blood pressure higher because you're retaining more fluid. So it's just important to be aware of when prescribing NSAIDs, to just be a bit careful. Obviously, if they've been using ibuprofen for years and years and years, then it's less of a worry. But if you're just starting them out, I'd probably avoid it and just stick with paracetamol and codeine in this instance. So, in this gentleman, we need to give him an antibiotic. Now, for dental abscesses, we normally prescribe either amoxicillin and metronidazole or co-amoxiclav if there's no penicillin allergy. But I thought I'd just touch a little bit on the different types of antibiotics because they kind of work on bacteria in different ways. Just because when you are dealing with patients in MaxFax, you're going to get a variety of different types of infections, not just dental abscesses. So it's important to know a brief overview of the mechanisms of how these ones work. You've got antibiotics that attack the cell wall, so that's the beta-lactams such as penicillins and cephalosporins. You've got ones that primarily focus on protein synthesis within the bacteria, so they target the protein synthesis and help to destroy the bacteria that way. So that's the tetracyclines, clindamycin, chlorphenicol, that sort of thing. You've also then got ones that focus on the more metabolic pathways of the bacteria. So that's your kind of trimethoprim. So some of you may have heard that used in urinary tract infections, but we're going to come on to that in a little bit, so don't worry about that too much. And then there's other ones that are more specialised that focus on nucleic acid synthesis, so like metronidazole, and then membrane integrity. So basically, that's just to summarise that there's different types of antibiotics and they attack bacteria in different ways. And that's why for certain infections, with certain bacteria, we use one preferentially over the other. Okay. So another way to choose antibiotics, and something else that we look at, is actually based on the likely organism causing the infection. So going back to your microbiology in dental school, there's gram-positive bacteria, there's gram-negative bacteria, and then there's anaerobes, so those that work in low oxygen environments. Now, the gram-positives are normally kind of, for example, like Staphylococcus aureus, that sort of thing. The infections commonly associated with gram-positive are skin infections, dental infections, and things like MRSA. And then gram-negative is mostly urinary tract infections, and then also lung infections, so types of pneumonia and things like that. Now, this is sort of an unwritten rule, because common things are common, but obviously any bacteria can cause any infection if given the right circumstances. So this is why microbiology guidance in the hospital and all the documents that they produce with the antimicrobial guidelines and things like that is so important, because they actually target the antibiotics to the bacteria that's prevalent in that region. So for example, it could be one type of bacteria that's causing all of the hospital acquired pneumonias in Scotland, but actually a different type of bacteria that's causing it, say, in Brighton. So it's important just to look at the antimicrobial guidance, because it might be that it's actually a different antibiotic that's first line to cover the infection in your region. Okay, and this kind of this chart shows what we mean by broad spectrum antibiotics and narrow spectrum antibiotics. So broad spectrum means that you are covering a lot of different types of bacteria. So gram-positive, gram-negative, anaerobes. So you can see down the bottom there, meropenem covers pretty much everything. So that would be broad spectrum, okay? And then moving on to something like metronidazole, that just covers anaerobes, which we know this is why we prescribe it along with amoxicillin. So it's just to bear in mind that certain antibiotics are used depending on what we know about the infection. So if we know that it's a dental abscess, we would prescribe amoxicillin and metronidazole. But if it's, say, a pneumonia and we don't know what's causing it, we might go something a bit more broad spectrum, just to cover all bases. So, for example, in a severe pneumonia, we'd prescribe piperacillin tazobactam, which is also known as tazocin, which covers both gram-positive and gram-negative. So you don't need to remember any of this, but it's more just to give you a bit of an overview of what types of antibiotics are out there and when you might use what. And this is just another little table, again focusing on the gram-positive and gram-negative versus the anaerobes. So this is just a little table about common infections that you might come across while you're working in MaxFax. Obviously, always consult your trust's antibiotic guidelines, which is updated regularly by the microbiology team. So I've just split it into penicillin and then penicillin allergy. So you've got your cellulitis, which would be flu clots in those who can have penicillin, or clarithromycin in penicillin allergy. Hospital-acquired pneumonia would be co-amoxiclav, and then doxycycline in the penicillin allergy. Just to know about doxycycline, you actually prescribe 200 milligrams for the first day, so a stat dose of that, and then from every day after that, it's only 100 milligrams, usually for 4 more days after that. For urinary tract infections, so it's not actually done by penicillin and penicillin allergy, it's actually done by whether you're male or female, and also children have a different type of antibiotic prescribed, but please consult micro for that. So for adult females, you normally prescribe nitrofurantoin, providing that their kidney function is, the eGFR is greater than 45. And for males, it's actually trimethoprim. Now, this is based on kind of the anatomy and the common bugs that commonly affect males versus females. So it's just to be aware that there is actually different types for gender as well as allergies involved. And then, as we all know, dental abscess, co-amoxiclav or amoxicillin and metro, that's also fine. And then penicillin allergy, potentially something like clarithromycin or just metronidazole. Now, going back to our case, so we have prescribed the analgesia, we have prescribed the antibiotics, but we also need to do an incision and drainage. Now, the majority of us would use LA with adrenaline for this, but we have to bear in mind that this patient is on a beta blocker. They are on atenolol for their blood pressure. Now, the way that adrenaline works, it actually binds to receptors in the peripheral vasculature and causes vasoconstriction, along with an increased heart rate. So that's why when we give adrenaline, people sometimes get an increased heart rate. Okay. Therefore, basically, if we increase the heart rate with the associated vasoconstriction as adrenaline normally works, this could actually increase the blood pressure in this patient and could be quite harmful. So it's just something to bear in mind that if this patient comes in and their blood pressure isn't actually that well controlled, that we maybe should be using LA without adrenaline in it. So yeah, it's just something to bear in mind. So either without adrenaline or keeping the doses of lidocaine with adrenaline to an absolute minimum. Yeah, so it's just something to bear in mind. So moving on to case 2 now. You are the SHO on call for MaxFax over the weekend, and you've got a 79-year-old male that's been admitted with a left submandibular swelling. They have a past medical history of AF, hypertension and COPD, and are on Tylenol, warfarin and salbutamol PRN. They've got a penicillin allergy, and they're a current smoker, non-drinker and are retired. Now, what sorts of things do you want to know about this patient? So you want to know their observations. So their heart rate is 115, BP 108/77, SAT 99% on room air, temp 37.6 and respirate 15. So what are you guys thinking of these obs so far? So hopefully you've picked up that their heart rate is quite fast, they're quite tachycardic, and they are quite hypotensive as well, especially knowing that they have a history of hypertension. 108 is fairly low for them. Now, what could be causing this? Most likely a bit of dehydration associated with the infection. So potentially the start of kind of sepsis, although the temperature is on the higher range of normal, so it's definitely something to just keep an eye on. Okay, so potentially dehydration, shock, or the start of sepsis. So looking at this patient on examination, they've got a left-sided submandibular swelling, which is quite firm and tender to touch. The mouth opening's about 2 centimetres. They've got a grossly carious lower left 6, and the rest of the examination is normal, obviously bearing in mind the obs that we've just seen. Okay, now what sorts of investigations would you get in this patient? You'd want to be getting an OPG, some bloods to see what's going on. And these are the blood results that have quite helpfully been taken by A&E. So as you can see, they've got a raised white cell count, raised neutrophils, and a raised CRP. Now, all of that, hopefully you should be able to recognise that all of these are in keeping with an infection, and because the neutrophils are raised, it's most likely a bacterial infection. Now, how would we manage this patient? Very similar to the last patient. Analgesia is important, so paracetamol, codeine, taking care with the NSAIDs, unless they have had them already. We're also having a separate talk on analgesia specifically, so please refer to that for any further questions on analgesia. Because this patient's being admitted and they're struggling with their eating and drinking, you'd want to prescribe some fluids, which is also important if we're thinking about taking them to theatre and they're going to be nil by mouth overnight. We've got a talk on fluids as well, so please see more details in the fluid prescribing chart. And then lastly, as well as prescribing all of their regular medications and general hospital requirements such as their low molecular weight heparin, etc., you'd want to give them some antibiotics. Now, of note in this patient, they've actually got a penicillin allergy. So how would that affect the antibiotics that we would be prescribing? Now, as you all know, people with penicillin allergy can't obviously have penicillin. But there's actually other drugs that they can't have, not necessarily containing penicillin, because there's a lot of crossover between antibiotics. So see the traffic light system that I've got on the right hand side. In true/severe penicillin allergy, so that's when it's the reaction is anaphylaxis, etc., etc. You can't give any type of penicillin. You can't give any first-generation cephalosporins or other beta-lactam antibiotics. Now, if you look back, or if you remember back when we were discussing about choosing an antibiotic and the way that antibiotics work, all of these ones in the red traffic light actually work in the same way. So it's not surprising that they would actually be contraindicated in someone with a penicillin allergy. Now, in those with a non-severe allergy, where it's a kind of minor rash or GI upset, antibiotics are to be used with caution. So you'd still be avoiding penicillin specifically, but you could trial other beta-lactam antibiotics, so or other cephalosporins such as cefotaxime, that sort of thing. And usually in hospitals you actually give a trial dose first. You give a slightly smaller dose and then go from there, and if they don't have a reaction you can then escalate up to the full dose, but there's normally protocols in place in the hospital for doing that. At the bottom, the green light is any antibiotic that is actually safe to use in a penicillin allergy. So as I say, if you were actually getting this in the hospital through A&E, you'd be looking at the microbiology guidelines in your hospital to see what they advise from a penicillin allergy point of view. But these are just a couple to have in the back of your mind that is safe to use. Okay. Just of note, there's certain antibiotics that actually contain penicillin but don't necessarily say penicillin in the name. So, for example, tazocin is actually piperacillin slash tazobactam, which contains penicillin. So just be aware that names might not be obviously penicillin, but they may actually contain penicillin. So it's worth just checking up on the antibiotics that you are prescribing just to check that they are actually safe. Okay, so in our patient, what type of antibiotic would you say that we could give him? So let's say he has a mild rash against penicillin. So as you can see, we can either give him anything in the amber box or the green box, and I think usually what we prescribe is clarithromycin. But obviously, depending on your trust, depending on what experience you've had before, go with what your local hospital recommends. Now, looking back at this patient's history, this patient is actually on warfarin for their AF. And as some of you may know, warfarin is a vitamin K antagonist, and this disrupts clotting factors and therefore has an impact on bleeding risk. That's how it works. So that's why when people are on warfarin, we check a blood test called the INR to check how predisposed the person is to bleeding or to clotting. Okay, so a high INR would mean that the patient is more likely to bleed, a low INR being the more likely to clot. Now, warfarin is actually impacted by a lot of types of antibiotics, and so the way that the antibiotics work actually increase or decrease the metabolism of warfarin, and basically make it either less or more effective. So the most common thing, so as you can see, warfarin becomes supratherapeutic. So that means it's becoming more effective. So the patient is at greater bleeding risk. So the INR would go up. Now, common antibiotics that may cause this is metronidazole, clarithromycin, erythromycin, those sorts of things. So especially if you're prescribing, say in this case, the patient with a penicillin allergy, you'd want to be checking the INR regularly to make sure that their warfarin doesn't need to be adjusted dose-wise. Quite rare, but there are some antibiotics that actually work the reverse. So they cause warfarin to be less effective, which means that there's a greater risk of clotting. And the bit of background behind this is that the antibiotic causes less clearance of warfarin in the supratherapeutic group. So there's less clearance of warfarin. So there's an increase in effect of warfarin because it's not being cleared. So then it increases the bleeding risk. And then for the subtherapeutic, it would be the opposite. So there's more clearance of warfarin, a decreased effect of the warfarin, and therefore a decreased bleeding risk and increased clot risk. Okay. So as I've already touched on, if you are in this position, you need to regularly check INR and potentially switch to another antibiotic if the INR is being affected, based on the advice of microbiology. So the key to this whole talk is that regarding antibiotics, if there's any concerns, speak to microbiology because they're the best ones to advise you on things. And that brings us to the end of this talk. Now, there are many other drug interactions, but these are the ones that you'll commonly come across in Max Facts. Obviously, any concerns about any drugs or any medications, ask your ward pharmacist. They're there in the hospital, a wealth of knowledge to just ask. Okay, there's also lots of other resources online. NICE, the National Institute for Health and Care Excellence, they have loads of guidelines on common infections and antimicrobial prescribing, so they're a good resource. But also there's the Show Me app, the BNF, and obviously our website for more information. I've just popped a little paper in there for common drug interactions in general dental practice for you to have a little look at. It's from 2014, but still relatively relevant if you guys want any more information. So that brings us to the end of the talk. Thank you so much for joining us. If you have any questions or any feedback, please feel free to email us on our email address. There's lots more information on our website or our Instagram page, which is OMFS Survival Guide. Thank you.